before that, let us have some poll, answer some of the questions which are put in here. Those who have just joined, once again, welcoming you to the CPHQ Introduction Training and CHQE certification. So when you attend our training program, full training program for the CPHQ preparation course, you also get a CHQE certificate, Certified Healthcare Quality Expert, because by virtue of attending the program and participating in it and solving some of the questions, you would have earned CHQE certificate. But once you, of course, prepare for the CPHQ and appear for the CPHQ examination, then you will be entitled to receive CPHQ certificate. And our passing rates are quite high. So I see that many of you are planning to prepare for the CPHQ examination in future. Okay. And okay, thank you for telling me that. Okay, meanwhile, let me play a formal introductory video as well before we start the program. Thank you for answering the question.
Hi, welcome to Anexas. Anexas has been consulting and training the professionals in the organizations around the world since 2006, and we have trained more than 150,000 people and consulted for more than 500 organizations, which includes Fortune 100 organizations too. I'm Amitabh Saxena, and I have designed this program based on my 30 years of experience while working in various industries across many domains. The whole Anexas team once again joins me in welcoming you.
So this whole program is brought to you by approximately 50 member teams spread around the world in various parts of the world, and more than 200 partners who are again working in various parts of the world. We'll start with what is CPHQ, what are the benefits, what are the modules covered in a CPHQ syllabus, and a little bit, very brief about the exam, not too much, because the idea is to introduce you to the CPHQ modules also, and also teach you some tools and techniques so that you get to know how much beneficial it is. Even though you are not going for a CPHQ certificate, but still by learning, by attending this program, by learning or preparing for the CPHQ, you gain a lot of skills whereby you can improve any process in your hospital or clinic or any healthcare industry. We'll talk about healthcare data analytics, which is the most dreaded part of your CPHQ exam. Means most of the people, if they fail, generally our participants don't fail, but suppose, I'm talking about in general, then the most failures are in the data analytics part. So we'll cover a little bit of data analytics today, and we'll introduce you to data analysis. We'll just introduce, we can't go into the details, obviously, but when you join our programs, then of course you can get to know a lot of tools and details. Now, about the organizations, we have been around since 2006, and for the last almost 15 years, we have been conducting CPHQ training programs, along with that Lean, Six Sigma, PMP, and recently AI and data analytics, data science, machine learning, and more than 150,000 people have been trained. And these are some of the photographs just to prove that I have personally trained. I'm something about me. I am a chemical. Okay, fine. I think the slide is not there, but I can just tell you that I'm a chemical engineer, but the husband of a pediatrician who brought me to healthcare data analytics and healthcare quality. and I'm a Lean Six Sigma Master Black Belt. Done lots of projects in National Healthcare Service in UK. And okay, let me play this video for you.
Well, we have
And
Alex with us, and he has done excellent Lean and Six Sigma projects in National Healthcare Service
so our
and
students have
in
really excelled
hospitals.
in
So,
different
Alex, would
fields
you like
in
to tell us
healthcare
something about
quality.
it?
Hello, I'm Alex Wells, Head of Service Improvement at the Royal Liverpool University Hospital. I've been really fortunate to present today on how us as a trust are using Lean and Six Sigma principles to deliver better care for our patients. I've presented today on a lot of the work that we've done around how we've improved patient outcomes, reducing mortality, improving length of stay, and also talked about how we can actually realise some financial benefits from that. Over the past 2 years, we've been really fortunate that we've done some good work, and it's actually delivered us £2 million worth of quality efficiencies through delivering better patient care.
So, and we have done a lot of quality-related improvement initiatives.
With us, who's CEO of King Edward VII Hospital in London, and we would like to.
So we have done a lot of work in Europe and Middle East.
commend you.
Now, almost all the biggest hospitals those who are from India, they can recognize. I've appeared on the TV show.
I am Shekhar Suman,
and,
and
spoken in American Society of
On
Surgeons
21st of May
conferences.
2019,
Last year, I had spoken about how to reduce nosocomial infections using the same tools and techniques, which are also part of CPHQ. Dr. Tarif Alama, earlier the Saudi Health Minister, and now Dr. Mohammad Abdul Ali. They are all have been our participants of our training programs. And so I think just to take it forward, I've got personally more than 35 years of experience in conducting quality-related training programs and almost all the big hospitals in Middle East, right from UAE, Saudi Arabia, starting with KFMC, King Fahd Medical City, then the Ministry of Health, and also International Medical Center. And my team can keep me reminding, Dr. Sulman View Hospital, the whole group. Many hospitals, means you name it. In Qatar, Sidr Hospital, then UAE Cleveland Clinic. So many, almost, we have covered almost all the big hospitals of Middle East. And we have conducted, and I have conducted quality-related training programs, and not only done the trainings, but also we have done projects. So you will be learning not only from a person who just talks about theory, but also who applies in reality. And I have done this personally. I have done many and guided many projects. And our team collectively has guided more than 15,000 projects in more than 500 hospitals across the globe. Okay, about the CPHQ trainings, Certified Professional for Healthcare Quality is an exam conducted by NAHQ, and approximately 17,000 to 9,000 healthcare professionals are at a given point of time certified, because the reason it is a floating population, because once the people get certified as a CPHQ, you have to also recertify yourself every 2 years by just there is no exam for the recertification. You have to just pay some fee, and you'll be able to get recertified. But many people don't recertify themselves, so that is why it's a floating population of around 17,000 to 19,000 certified people at one given point of time. And it is talking about, see, it is how would you get your CPHQ? You have to pass an examination, and let me tell you, as this is a very introductory program, I'll not go into too much of details, but very briefly, I can tell you that there are 140 questions in the examination, and out of that, 15 questions are pre-test questions, means they will not be giving any score on these questions, but they would like to know how the people react to these questions. So obviously, you don't know when you are appearing for the exam, you don't know which are these 15 pre-test questions, because they will be hidden within these 140 questions. So one of the tip is that don't spend too much time on any question, because if you spend too much time on any question, and if that question is a pre-test question, you're not going to get anything out of it. And apart from that, also, it makes good sense to not spend more than 1.5 minutes to 2 minutes on any question, because if you spend too much time on some questions in the beginning, you will be left with no enough time to answer the questions which might be easier for you. So time management is also important, and we train you in all these things when you join our courses. And yeah, so 125 questions will be scored questions, and you have to answer them as quickly as possible within 3 hours. So within 3 hours, you have to answer 140 questions. So you can imagine very, very less time is there. So you have to be well prepared. You should be well prepared, and we train you in the classroom really well so that you don't have to think too much. You can give the answers easily without spending too much time on calculations and thinkings. Yeah, so I think let us continue now. Now, when you are appearing for CPHQ examination, you learn in 7 modules. So what are these 7 modules? First module is quality leadership and integration, where you learn what is strategic planning. And as a quality professional, you have to guide the senior management. You have to guide the senior management in how to integrate quality in the strategic business objectives. So all the quality professionals, CPHQ professionals, they act like internal consultant to the senior management. They assist with the development of action plans or projects. They assist with establishing the priorities, and whatever you want to improve. The best way to improve any system is by taking up projects. What is the definition of a project? Project has got a starting point and end point. It doesn't exist after some time. As against the process is repetitive in nature. It goes on and on and on continuously. So process is repetitive steps repeated again and again. But project is one-time endeavor. So when you want to improve something in your hospital, you need to take up improvement project. Projects are done in teams. So we also learn how to work in team, how to form the teams, etc. Then we also have to, when the people are working in teams, we have to identify the stakeholders when we are working on projects. We have to identify our stakeholders. Stakeholders are those people or institutions or groups or departments which are positively or negatively impacted by our project, improvement project. So you have to identify them, and you have to manage them so that you get their support. So that part is also covered in the quality leadership and integration. In the beginning, those who joined a little early, I showed you the video of leadership. So you need to learn a little bit of leadership theory when we are appearing for the CPHQ examination. And we teach you all styles of leadership and how to be a good leader and how to write great strategies. What is vision, mission? Vision is how you see yourself in the future. In 2030, how do you want to see your hospital? How do you visualize your hospital? That's your vision. And to achieve that vision, let's say you want to become #1 pediatric hospital in the city. So in that case, to achieve that vision, you will have some strategies. You can achieve your vision by buying the best equipment, or getting the best people, or maybe lowering the cost so that you can serve more patients. You can achieve #1, become #1 in various ways. What is your strategy? And based on that, you create your strategy, and then you create your strategic business objectives, and that's how leadership comes into picture. Okay, so as a quality professional, you have to be able to create strategies so that you achieve the vision of the hospital, or your clinic or your lab. Quality review and accountability talks about lots of topics which are about applying the standards, best practices, and other information from other quality-related organizations. So here you learn how to benchmark, what are the other institutions whom you can look up to, and how to maintain the confidentiality of the performance, quality improvement records and reports, implementing and evaluating the quality initiatives that impact the reimbursement, all these things. Because you are also, your hospital is getting some funding from various institutions, maybe the government or different bodies. So how to get these funding by ensuring their quality, your quality is really good. So that's how you contribute as a CPHQ. So when you see in the bracket 19 items, the first quality leadership and integration, 19 items, you have 19 questions. Then here you have 16 questions. Then next is patient safety. You have 18 questions. So here you learn about identifying the technology solutions to enhance the patient safety, facilitating the ongoing evaluation of safety activities, etc. And here you learn tools like FMEA, systems thinking. What do you mean by systems thinking? Probably I will start with systems thinking. I'll give you an overview of systems thinking in the beginning before we proceed into the tools and techniques and the data analytics parts today. So today I've decided to talk about a little bit of some topics from different modules. So I'll talk about systems thinking. I already spoke about leadership in very brief. Then we will also go further, and we'll also touch upon some of the ways to analyze different types of data. Before I proceed further, let me also take you through the modules. So we have seen 3 modules. The first module is quality leadership and integration. Second is quality review and accountability. The third is patient safety. We have regulatory and accreditation, like how to prepare for the accreditation journey, how to choose our accreditation, SIBAHI, JCI, NABH, whatever you are going for. Evaluating the appropriate accreditation, certification, and recognition options. Then how to proceed with the journey, and then how to support the whole journey, and how to also prepare for the surveys. So that's what is covered in the module 4. Then module 5, we talk about performance and process improvement. Now you can see here 27 questions. So here you learn about different improvement methods like Lean, Six Sigma, PDSA, PDCA, FMEA, fishbone diagram. So today I'll spend a little bit of time on that. I'll spend good time on this, showing you some examples and also showing you some analysis. Plus, you also will learn today. So here you can see 27 questions for performance and process improvement. Then we have got healthcare data analytics, 26 questions. So here you learn about basic statistics, mean, median, mode, standard deviation, then scatter plots, box plots, how to analyze the data, how to find the root causes of the problems, doing the root cause analysis. Yeah, so some of the advanced topics of that part I can cover. So today I'll cover a little bit of Lean, a little bit of Six Sigma, FMEA, maybe I'll not have time to cover, but what I'll do is I'll give you a video, FMEA. You can watch that video. FMEA is failure modes and effects analysis. It is a tool to prevent the failure. FMEA means failure modes and effects analysis. It's a tool to prevent the failure. So you imagine how you will fail, and then you take a preventive action so that you don't fail. So we'll also learn about like structure measures, process measures, outcome measures, SIPOC. What do we mean by SIPOC? And what is quantitative data or qualitative data? So today I'll touch upon these topics also so that you gain some good insight, so that when you go back next week, at least some of the knowledge you would have you would have gained, which you can apply immediately to improve your processes. Yeah, measurements of central tendency, standard deviation, correlation. Very, very briefly, I will touch upon these topics today. Then we have population health and care transitions, means how, as a quality professional, you can contribute. You can contribute to the general population health, and how to ensure that the transitions are seamless, how to identify opportunities for improvement in care transitions, collaborating with stakeholders to improve and optimize the care processes and transitions. Now, these are the topics which we cover in population health and care transitions. There are 11 questions for this. Okay, so what I will do is I will not cover today the. Okay, let me cover a bit of that. I promised that I will cover systems thinking. So let me talk about system thinking. What is systems thinking? Systems thinking was given by Dr. Deming, and he said that when you are a leader or you are a manager, you should think about the systems. You should not have silo thinking. So let us see what is silo thinking and what is systems thinking. So here I will yeah. So in the leadership module, I'm right now today I have picked up small topics from different modules for our introduction to CPHQ. So systems thinking, let's look at the systems thinking. What is systems thinking? So when you talk about 5 levels of leadership, I have already spoken in the beginning. I played this video, so I'm not going to talk much about it. Those who joined late, they can watch the video. This recording of the session is definitely available on the YouTube. Think about your hospital. Okay. You have inputs, and then you have outputs. Think about your lab, your hospital, your clinic, or your department. So this is a model of all the organizations in the world. You can treat it this way. So you get certain inputs, like you have patients, patient history, information, knowledge about equipment, skills, etc. These are the inputs. Through a series of process steps, you provide an output. For a hospital, this output could be a treatment. See, outputs are either a product or a service. Okay. Outputs are either a product or a service. So you have products or a service as outputs. In case of, let's say, a hospital, some examples of outputs are treatment, medication. And these outputs go to the customers. And of course, suppliers are supplying the inputs. And we have a strategy team, a planning team, which based on the feedback of the customers, they tell the suppliers to provide the inputs, and also sometimes they predict the demand of the customers. Based on that, they plan their operations and inform the different departments to change their parameters or ways of working, or SOPs. Sometimes you have to change the SOPs based on the feedback of the customers and also looking at the demand of the customers. So this is how every system operates, and we call this as a value stream map. Okay, we call it as a value stream map. So you have to think like Deming was a quality guru. He used to say that leaders have to think in terms of the systems, have systemic thinking, not silo-based thinking. What is silo-based thinking? Silo-based thinking means I belong to department B and I don't care. So I am from B and I don't care what's happening in A, what's happening in C. But actually, systemic thinking means I'm part of the system. I'm an element of the system, and our system is delivering value to the customers. Here, patient is our main customer. So patients and shareholders are the main customers. Sometimes governments, they are the main customers. So customers are looking to obtain value from our outputs. So our job is to deliver value. What is the value? Some of the value the customers are looking at is good health. Good health is that value which a customer or patient is looking at. Shareholders are looking at increase in wealth. We're talking about the private hospital, or if it's a government hospital, then the value is the well-being of the population, well-being of the citizens of the country, the health of the country, countrymen. So that's how you get a value. So the value is created through a series of steps. That is why it is known as value stream map. So this is known as systems thinking. I hope you are with me. Now, how will I measure value? See, you cannot improve if you cannot measure. Yeah, you cannot improve if you cannot measure. Yeah, so I hope you just let me know. Okay. I see a lot of people. Yeah, if you have any questions, you can still ask. I will try to reply them towards the end of the session, if that is fine, unless something is very, very critical. There is a question Q&A also here. You can put your questions there also. And feel free to keep asking questions as we go along. And let me know if my pace is okay, my speed is okay, or should I increase the speed or should I reduce the speed? Just let me know. Okay. Okay. Mr. Amal Adam. Okay. Thank you, doctor. Thank you. Okay. Okay, great. Now let me talk about a little bit of lean. Let us take what is lean concept, some Six Sigma concept, some data analytics concept. Are you okay if I see? Data analytics is considered to be the most difficult topic in CPHQ. Are you okay to learn that topic? Because it's an introductory program. Some of you should not feel that, it has been like, it is very complicated. See, most of the topics, 50-60% of the topics are very easy. Say leadership topic is very easy. Strategy topic is very easy. Patient safety is very easy. Say accreditation is very easy to understand. Data analytics and process improvement, the two modules where you have got almost 60 to 65 questions. It is considered to be difficult. See, we are expert in data analytics. So for us, it's very easy and we make it easy for you too. So I think Saida is telling, Siraj is also telling that you're fine. BS is telling that we would like the idea of data analytics. Yes. Okay, so before that, let me talk a bit about lean concept also. See, when you look at your typical hospital environment, there are service breakdown and wasteful processes and medical errors. So let me talk about waste, the 7 or 8 waste. Let me talk about that today. I keep changing my topics in every introductory program You can also look at my previous recordings if you are interested about my CPHQ introductory program. And also one more thing, those who are interested, they can always join my CPHQ programs. I conduct the programs on every Saturday. Saturdays, we have 4 Saturdays, continuously, mostly. Continuous 4 Saturdays. We prepare you for the CPHQ examination, and we also solve some mock exams. We give you mock exams, and if you just attend our session and just read the material given by us, that's good enough. That's good enough for you to pass the CPHQ examination. And our material is coming from NAHQ. We are following NAHQ module, so it totally falls in line with NAHQ, with what the NAHQ expects from you. So there are 7 types of wastes. There are 7 types of wastes in any process. We can call it as I swim to, or if you rearrange them into different order, Tim Woods. Okay, Tim Woods. Now let's take some examples. What are the different types of waste? Let us take a simple process, a blood test. Walking to the OPD. Is it adding value to the customer? See, when we look at the decision to categorize any step as a value-added or non-value-added step, see, value-added step is something which the customer is willing to pay for. Customer should be willing to pay for that step. That is value-added. It should be done right the first time. Means you should not redo it. Review, anything starting with re is a waste. And also it should be bringing the input closer to the output. So that means it's a value added. Those steps which are not value added, they are called as wastes. And that's why we were referring to this 7 or 8 wastes. Now, these are all different types of wastes, also called as muda in Japanese. So just one example of waste of intelligence. See, in the hospital, 80% of the nurse calls are of housekeeping in nature, like my bed cover is dirty, my pillow cover is dirty, all these things. 25% of the calls were requests for room supplies like bed sheets and tissue paper. Now, if you engage the nurse in all those activities, she will forget to give the medicine. So that is known as waste of intelligence. Means a person is capable of doing better things, better jobs, but he or she is involved in something which can be done by someone else. So much of qualification is not needed. So this is waste of intelligence. Some more examples I'll just give. Using these lean concepts, which I was just mentioning, we could double the cardiology lab capacity from 8 to 16. A lot of case studies we have got. We have done many projects in US, in Europe, and Middle East, in Japan, India, Australia also. I'm a permanent resident of Australia, but most of the time you'll find me in Middle East. Tomorrow I'm traveling to Qatar. After that, I'll be in Saudi Arabia. So there are lots of case studies we have got where all these achievements which are listed here have happened. What did we do? We used lean techniques. Okay. We could reduce the diagnosis exam from 2,743 minutes to 64 minutes. A CPHQ professional knows these tools and techniques. They learn the tools and techniques so that they are able to achieve these improvements. Yeah. Reducing the signatures. Approval is a non-value added activity. It's a waste. So you have to remove the waste and create value. Typical patient flow, when you map it, you have to find which is value added and which is non-value added. Each and every step has to be critically evaluated, which is value added and which is not value added. Yeah. Our team has put 7 types of process waste YouTube I think that this is not, it is not in the link format. If you can put this in the link format too. So you can just store that. Okay. I think enough. I think I've spoken enough. See, I've got a lot of material. Within 2 hours, I've got like limitations, but yeah, a little bit, maybe some more time I'll spend on this lean part, then we'll move to the data analytics part. Some other examples of waste: unnecessary process or motion, unnecessary waiting, unnecessary transportation, error, unnecessary stocks of production. These are all considered as waste. A person who's not utilized or underutilized is a waste. And any equipment not utilized or underutilized is a waste. Even overutilization is also a waste. Cost of 5-minute empty walk, or walk to elevator, elevator wait, elevator travel, walk to lab or pharmacy, nurse cost per hour, cost of one trip. So if you see it, cost of 200 nurses in a hospital during the whole year can run into millions of dollars just for the elevator wait. So these are some of the surprises which are in store for you if you are looking from quality person's perspective. Lab and pharmacy on second floor, radiation equipment on ground floor. If you bring them on same floor, you reduce the waste of walking. And waste of walking is productivity loss of the employees of the hospital, apart from, of course, the patient. Now, any exam room interruption is a waste. Similarly, many hospitals we have done this project. If you look at admissions, they follow this pattern with respect to the time. This is the time. But the discharge of the patient, they take towards the evening. So you can imagine the beds are going to be vacant in the evening, but the patients are waiting since morning. So if we make this as well, and we have reduced the patient discharge time in many hospitals, Today I'll show you, while I'm giving you some knowledge about the data analytics, I will show you how this, this data is collected and how this data is analyzed. So here, if you see, if you reduce the patient discharge time, you can discharge the patient almost simultaneously as we are getting the patient admitted. Otherwise, patients will go to the other hospital, because here you see the beds are not vacant and or they're not available because the patient discharges have not taken place. It's a waste, it's a loss. Some other examples, there is one more thing called Pokayoke. Pokayoke means mistake proofing. Even by mistake, you should not commit a mistake. So as a quality professional, you should have lots of Pokayokes in place in the hospital so that you reduce the errors. Yeah. So these are some examples of reducing the errors using visualization, visual tools, intended surgical instrument tray so that you don't forget anything. And your hospital should be a visual hospital. People should not ask too many questions. The patient should not keep on asking questions. It should be indicated everywhere. Where are the different departments? So you minimize the questions asked by the patients. It saves the time of the staff also and saves the time of the patient also. Make it as a visual hospital. Yeah. Rice cooker is an example of Pokayoke. Pokayoke is a Japanese technique which means foolproofing. Foolproofing means even a foolish person cannot commit a mistake. Foolproofing. Even if you want to commit a mistake, you cannot commit a mistake. Some examples. I think some machines cannot be operated or even set beyond normal, safe, or maximum levels. It's Pokayoke. Even by mistake, it should not happen. Yeah. Similarly, abnormal ranges will be rejected. Oxygen and nitrogen, they have got different connections, different types of connections. Even by mistake, you cannot connect each other, or you don't connect nitrogen and oxygen line or oxygen nitrogen line, even by mistake, because of the differences in the connections. Some more examples: fixed number of packages during the surgery, complete catheter kits for insertion, and prepackaged medication card for correct dosage. These are examples of okay to prevent the errors. Now let us look at the data analytics part. Now, see, you cannot improve if you cannot measure. Okay, there are 3 rules to remember. You cannot improve if you cannot measure. The second rule is you can measure everything. The third rule is if you think something cannot be measured, go back to rule number 2. Okay. By the way, I have got lots of videos too. These videos are available on our YouTube channel, Anexas YouTube channel. You can always subscribe to that channel, and you can do self-learning, a lot of self-learning you can do. And of course, I conduct a specific CPHQ training program. Every month, we start a new batch Saturday. You can always join us. Yeah. So 2 types of data. So we told you that everything can be measured. Now you'll be wondering, how can I measure so many things? So let me tell you that there are 2 types of data. One is known as continuous data and one is known as attribute data. Also known as quantitative data, and we have qualitative data. Quantitative and qualitative. Quantitative data has a possibility of a decimal point, and good sample size is 30 to 50 for that, to make a judgment about the whole population. And then attribute data is something which has got categories. It's categorical in nature: good, bad, infected, not infected. And here the thumb rule is that 200 to 1,100 samples will give you a good information about your process. So these types of data I have given. So what I'll do, I will first show you some projects. And the Six Sigma approach is Lean, Six Sigma, PDSA. These are the most popular approaches. Let me show you one project, which 1 or 2 projects. But first, I'll show you a project, how a typical project is done. And after that, I'll go into the details of each of these projects. My team can keep telling me how much time is remaining, so that accordingly, I will adjust my time. So we'll be learning about, I'll show you some of the graphical analysis also. Today, I'll just show you, when you come to my class, I will show you how to do this analysis. We do it together. In fact, we solve some problem also. Taking a problem in the hospital, we do a project also. So here, I was telling that project approach is the best approach to improve a process. So when you are doing a project, you write a project charter. First, you write a project charter and you write a problem statement. Here, the problem statement is the OPD waiting time is very high and they would like to reduce from 93 minutes to 30 minutes. And then you create your project timelines. And then after that, you make a SIPOC, supplier input, process output, and customer. Now, just to take you back, we learned about systems map. Yeah. Now, if you pull S of suppliers, I for inputs, and this is process. A, B, C, D is a process. P for process, O for output, and C for customers. You get a SIPOC. So SIPOC helps you to understand the bigger picture, to understand how the bigger picture looks like. So this is supply and input, process, output, and customer. It's like a systems map. It's like a mini systems map. It is like a 50,000 feet view of your process. Basic 5 to 6 steps you have to write. What are the outputs? Who are the customers of those outputs? What are the inputs? And the customers are always interested in the outputs and the measures of the outputs. Some of the measures of the outputs which the customer is interested in is time, cycle time. You should do the job fast. 2, costs. Your costs should be low. And the 3 is about errors or defects. So these 3 measures are always there. Always you'll find. Okay. So these measures are always on the output. Now you can't do anything about the output. You can't reduce the time just like that. You can't reduce the cost just like that. You can't reduce the errors by just wishing that errors are reduced. You have to attack the process and the inputs. The problems are in the processes, not in the people. That's what Deming said. Means when you want to improve something, look at the process, change the process, rather than badgering the individuals about, please perform well, not doing well, etc. You have to first, results are not in your hand. You are not doing good. We are having a lot of infection. The turnaround times are high. Patient waiting time is high. These are all output measures. We call it as output measures. Remember this, output measures. What are process measures? Process measure is time taken to register and assign the doctor, time taken to consult the doctor. These are all examples of process steps. Inputs. Again, the measures of inputs is also like doctors. Doctors are available, not available, receptionist, skilled, not skilled. You're not leaving any stone unturned. So you are getting your X factors which might influence your these are known as X factors. Okay, these all measures are known as measures on factors is known as X factors, and here it is known as Y. We call them Y factor. I hope it's not too complicated. Yeah, you are with me up to here. If you are, should I make it more complicated? With your permission. Okay. So before I go to the measure phase, so we can do that. Okay, great. So, okay, first let me give you the overview, then I'll come back to my topic of 2 types of data. Okay. So when to use which tool in the analysis, you will get to know. So when you are displaying in the measure phase, generally, I'm describing define, measure, analyze, improve, and control, the 5-phase approach of Six Sigma right now. So when you are looking at measure phase, so this was defined, what I just showed you, project charter and CPHQ is define phase. Then you have measure phase. Measure means you collect the data, you understand how you are performing. And that is what is measure phase. You're collecting the data, you're making histograms. Most of the histograms will follow normal distribution, the way you look here. It's a bell-shaped curve, if you see. If I take the data of all the participants who are attending this seminar today and take your salary, they are normally distributed. If I take your heights, they are normally distributed. It is known as normal distribution because it is normal to obtain a normal distribution in any process. So after you have measured and how to measure, there are so many good tools available. We teach you Excel sheet, basic Excel sheet. Sometimes if you are interested, we can teach you advanced statistical skills also during my session in CPHQ session, although they don't ask too many tough questions on data analytics, but we prepare you so well. We give you more than required so that everything, when you are appearing for the exam, everything looks like a simple thing. Okay, so we are getting that understanding of the process. We are seeing how our process is performing, what is the average, what is the standard deviation. Yeah, average and standard deviation. Now, why we are performing like that? Why this patient waiting time is high? Because of many reasons. We call it as cause and effect diagram, Ishikawa diagram. Ishikawa. So here you brainstorm on man, machine, material, method, etc. Or you can create your own branches also. But try to generate as many reasons as possible. These reasons may not be so. See, don't evaluate the reasons when you are brainstorming. You should not evaluate. So when you are brainstorming, you have to follow certain rules. Let me tell you those rules. So when you are creating your cause and effect diagram, you should follow certain rules. And I'm just telling you, let me. Yes, Saibur, you had raised your hand. So you have a question? Raminder Singh also has raised her hand. Yes, you can write your question here in the chat box. Okay. So I think you have any question, you can write in the chat box. Yeah, I can see that immediately. Okay. So as I was telling, these videos are also available. Let me first play this for you. These videos are available on our YouTube channel. And also in a very structured format to everyone who joins our program. These videos are available in English as well as Arabic and Hindi as well.
You think something cannot be measured, then probably it is attribute data. Now let me tell you, how can you measure anything? There are two types of data, continuous data and attribute data. Continuous data can be represented on a number line. It can have a decimal place. It can also have a unit. Say, for example, age, height. Age is 52.5 years. That's my age. Height, maybe 180.1 centimeters. Cycle time of a process, 3.5 hours. Or procurement time in an organization, 120.3 days. These are all continuous data because they all have a possibility of a decimal, means they can be expressed in decimal points, and also they all have a unit. Now let us talk about attribute data. Attribute data can be expressed in categories, and categories can be counted. Say, for example, if you want to measure happiness, so easiest way to measure any attribute data is to create a category, and if possible you can create a binary category. A presence or absence of that attribute can be one of the simplest categories. So if I take the example of happiness, two categories I can create: happy, unhappy. So if I want to increase the happiness in the employees in the organization, then I can always count how many employees are happy. Let's say 60 employees are happy and 40 employees are unhappy. I can express this as proportion. That means proportion of happy employees in my organization is 0.6 and proportion of unhappy employees is 0.4. And it can also be expressed as percentage. Now this proportion or percentage, they don't have a unit. and a count like 60 employees, I can't have 60.1 employees who are happy. So the count will not have any decimal point. So this is what continuous data and attribute data is. It is very important to know the difference between continuous and attribute data. And it is very important to understand what is continuous data and what is attribute data, because the tools which you are going to use in the measure and analyze phases, they depend on what type of data you are dealing with. If you are dealing with continuous data, then you might use histograms. If you are dealing with attribute data, you may use pie chart or Pareto charts or bar charts. If you are dealing with combination of continuous and attribute, like in inferential statistics, then you may be using box plots and scatter plots and regression, ANOVA, chi-square, etc. So the tool usage depends on the type of data you are dealing with. So it is very important to understand the types of data. More about it, we will discuss in measure phase. Also,
okay, so this was about, I hope you understood. Let me explain this a little bit more. See, sometimes we feel that a lot of things cannot be measured. So the answer to that is think in terms of attribute data. Whatever attribute, like here, happiness is being measured. How did we measure? By creating two categories: presence or happiness, or absence or happiness. Okay, like pain. Pain is an attribute data. So pain scale, you can have 1, 2, 3, 4, 5. That's pain. 1 to 10 scale is not continuous data. Actually, it is attribute data. I hope you agree with me. Then how many times you feel at 1, 2, 3? You know, that's how you can deal with. So if I continue with the example of happiness, you have a count here. Count, 60 people are happy, 40 are not happy. So our happiness index, let's say you want to improve the happiness of your staff. You are at 60%, you would like to make it to 80%. So you do some improvement project. That's easier to improve. Happiness is easier to improve if you take an improvement project. And then you have got proportion. Proportions means portion out of 1. If the circle is 1, let us say the circle is 1. What is the portion belonging to happy? 0.6, 0.4. Or sometimes percentage. Percentage means the circle is 100. So in this case, this is 60% and this is 40%. Okay. Now, what is the use of this? So the tool, when you are analyzing your data, you will always choose your tool based on the type of data you have. So when you are, okay, let me directly show you. I was referring to, see, when you are dealing with continuous data and you want to just analyze single column, you can use histogram. Okay? You can use graphical summary or histogram. When you are having attribute data, you can use Pareto chart, bar chart, or pie chart. Okay? So if you want to just comment about any factor like cycle time, infection rate, cycle time, you will make a histogram. Infection rate, you will make a bar chart or a pie chart. Okay. When you want to correlate two factors, one is continuous and one is attribute, you will use box plot. One is continuous, both are continuous, you'll use a scatter plot, or both are attribute, you'll take a Pareto. So let me give an example and let us take you through the same thing. So we have project charter written, CPHQ, we have had a process understanding. Now a CPHQ professional who believes in systemic thinking, not silo thinking, also believes in another theory given by Dr. Deming, that problems are in the processes, not in the people. Because no staff of a hospital enter in the morning thinking that today I will commit 50 mistakes. Collectively, we will commit 50 mistakes. But by the end of the, say, day, they have 50 mistakes. I'm just taking an example for a large hospital. I'm just taking an example. Or none of the people who are walking in the morning into the hospital, they have a target that today we will ensure that we receive 100 customer complaints. No one has that target. But by the end of the day, you have 100 customers. So who's producing these customer complaints? Who are producing these mistakes, errors, delays? It is our system, the way we operate our processes, the kind of SOPs we have, the kind of trainings we provide, the kind of equipment we have, the kind of policies are in place. They are responsible for those errors, defects, delays. So you have to think in terms of errors, think in terms of systems, not in terms of people. Okay, so don't blame the people. That's what this means. That is why CPHQ is being prepared, and that's why that's how you enter. Then you make a histogram. Why did you make a histogram? Because patient waiting time is a continuous data. So we could make a histogram. Histogram looks like a bell-shaped curve. Most of the time, you are taking 90 minutes and sometimes 95, 100, and 105, sometimes 85, 80. Yeah. And then you create a cause and effect diagram. One more thing, when you are creating a cause and effect diagram, you have to follow certain rules when you are brainstorming. You have to brainstorm. So let me show you some of the rules of brainstorming techniques, how to brainstorm properly. Okay, so just it's a 3-minute video. Let us watch.
There's excitement and energy within the team members, and it separates the people from ideas they suggest. There are certain prerequisites of conducting a brainstorming session. They are very simple, but they should not be ignored. First, the purpose of brainstorming should be clear to everyone who is participating in the brainstorming. So it's better to give them the topic, tell them what exactly is the purpose of brainstorming in advance. Participants should be from the process or may not be from the process. You may also like to invite the people from other departments to get a fresh perspective. You should also have a facilitator. Facilitator is generally the person who is not participating in the brainstorming. Means he's not participating in generating the ideas, but he or she is facilitating the whole session. Usually, he or she can be a consultant or a person from another department, or one of the persons from the team can act as a facilitator. You should also have stationery, and you should also use the appropriate tool of brainstorming. So there are different brainstorming techniques we will be learning in improve phase. You can use either of them. You should have a meeting room and flip charts and other facilities, whatever is required to conduct a brainstorming session. And you should also communicate to the participants about the time, venue, topic well in advance, so they are mentally prepared for brainstorming. As I told you that brainstorming is used for either generating the possible root causes or getting the ideas to solve the problems. There are certain rules which need to be followed in brainstorming. The rules of brainstorming are: give equal opportunity to everyone who is participating. So tell them to participate, and you can use different techniques. As I told you, we will be learning in the improve phase. Capture all the ideas, so document all the ideas. Whatever is being discussed, whatever ideas the participants are given, someone should be there to document, or a scribe you can appoint to document all the ideas. Leave your designation and ego along with your shoes outside the meeting room. That means don't think that if you are senior, your idea carries more weightage. So obviously this ground rule should be very clear to everyone, and everyone should be encouraged to give an idea, and everyone's idea should carry equal weightage. There should be a non-threatening environment. When people are giving ideas, they should not be afraid of giving ideas. So you should create an environment where people should be encouraged to give the ideas. Also, we should ensure that that wherever the brainstorming is taking place, there should not be any disturbance, so people are focused on brainstorming. Sometimes people might deviate from the topics. There is a tendency that some important issue crops up during the discussion. So at that time, you can always create a parking lot saying that, well, this idea or this issue is very, very important and we can park it to be discussed after a while once we complete the brainstorming on this particular topic. We should encourage people to fantasize freely. We should not put brakes on our thoughts. So you can give some out-of-the-box ideas, you can give some wild ideas, and if people are giving you wild ideas, they should be encouraged. If you give a specific duration of brainstorming, we should try to complete the brainstorming within the time duration and defer evaluation. Now, this is one of the rules which is often violated. People start discussing the ideas. Someone gives an idea and someone else says, well, it will not work in an organization. Or some other person gives an idea and someone else comments that, wow, it's a great idea. So don't evaluate. Reserve your comments for evaluation at a later stage. When you are generating the idea, when you are generating the root causes, they are not to be evaluated. You cannot say that it is a good idea or this is a very good root cause which you have thought of. No evaluation, just write down whatever is being suggested. Generate quantity, do not worry about the quality at the initial stages. So you have to generate lots of root causes, lots of solutions, more the better. A pearl diver, he dives into the sea to find the pearls. If he just collects 10 oysters, the probability of getting the pearl is very low. But if he collects thousands of oysters, the probability of getting the pearl is very high. So similarly, if you want to collect great ideas, some of the out-of-the-box ideas, some creative ideas, then definitely you should create more and more ideas.
So these were some of the basic things, basic rules which you have to follow when you are thinking about the idea. So using those rules, they created a cause and effect diagram, also known as Ishikawa diagram. You brainstorm on all the possible causes. And then we apply Pareto to that. Pareto means Vilfredo Pareto was an Italian economist who found that 80% of the wealth in Italy was with 20% of the people. Or 80% of the land in Italy was owned by 20% of the population. So he applied this the principle everywhere. He saw 80% of the crop production was coming from the 20% of the crop types. And similarly, doctors will tell you that 80% of the patients are coming from 20% of the diseases. So you may be treating 100 diseases, maybe, but 20% means 20 diseases are responsible for 80% of the patients. And yeah, so this 80-20 rule is applicable everywhere, and it is also applicable to quality. That Joseph Girard brought this to quality, and he said 80% of your problems is coming from 20%, the root causes. Only 20 causes are responsible. Which are those responsible causes? You have to find out. Okay. So after that, you do Pareto analysis. Pareto looks like something like this. 80-20 rule means how many times registration is responsible, how many times doctors' availability is responsible. So you can see out of many instances, 43% were contributed by the registration time issue, and registration was the issue there. And around 25% of the time, it was the doctor which had the issue. So here, these two are the main root causes for your problem. And you can validate them using box plots and scatter plots. Anyway, I will show you some examples in real life after a while. But just to complete this particular project, just to show you, they found the root causes, they acted on the root causes, and once they acted on the root causes, they were able to bring down the patient waiting time drastically. So before and after, when you see, there was a huge difference. Another project was to reduce the waiting time for MRI scan. And here, average number of daily exams before the project were around 10. Now they put one more machine, one more equipment they put, thinking that it will reduce the waiting time. But that equipment did not actually, it did not reduce the average, it did not increase the number of daily exams. Earlier, they thought that it will increase by getting a new equipment, but it did not. In fact, both the equipment, they distributed the existing number of exams. So every equipment now took over 4 to 5. So overall, it was 10. So they collected the data and they found that there were some root causes. They did some fishbone analysis. They did a lean examination, the Gemba. Gemba means go to the field. Gemba means go to the place of action and identify the waste in your system. This is done by walking, walking to the workplace. I'm giving you a very brief overview, introductory part, and I hope you are able to understand, because the idea is to give you exposure to as many concepts as possible in the shortest possible time of 2 hours. So here, what we did was that once we found the root causes, we acted on the root causes, and these solutions were implemented, and that's what a CPHQ would do. And once it is implemented, they started creating the master schedules from patients' arrival pattern perspective, not from their perspective, or not from their convenience perspective. So earlier, the whole master schedule was prepared, keeping in mind the convenience of the doctors and nurses. At this time, the master schedule was prepared by taking into consideration of the patient's convenience. So they changed it, and they were able to increase the number of daily examinations. So this is how typical projects are done. Now let me show you one project, like a little bit in detail. Oh, FMEA is also there, failure modes and effects analysis. I may have some time to talk about it. So maybe I will take you through the FMEA also, failure modes and effects analysis also. My team has put in some YouTube videos, links. You can always watch these links, and you can also get more information about these tools. So let me show you one more example from the raw data perspective. This is for demonstration only. When you come to my classroom, we do these things together. Whatever I'm doing, I teach you as well, so that you can master them. And more importantly, you should be able to answer these questions with much ease when you face these questions. So we have this data about patient, and we want to reduce the patient discharge time. Okay. So this is, as a CPHQ, you want to reduce the patient discharge time. So what you do is you do a histogram, and you find that average is 300 minutes and standard deviation is 25 minutes. Okay. Average is 300 minutes and standard deviation is 25 minutes. And most of the processes, they follow normal distribution. Normal distribution looks like a bell-shaped curve. It was given by Gauss, Carl Friedrich Gauss. Looks like this. Your all waiting times, traveling time, time taken to perform a surgery, everything, anything continuous data, age of the patients, everything follows this normal distribution. Also, Mr. Gauss told one strange property of a normal distribution curve, that he said that very important, interesting property. He said that if you get your average and standard deviation from a sample, and I'm talking about the sample, not about the population, just collect 30, 40 samples from any population, And you would be able to get the average and standard deviation very easily. The way I showed you, in Minitab you can get, in Excel sheet also you can get. So suppose let's say, let me take a simple day-to-day life example. Suppose you are traveling to your office every day and you are taking one day 30 minutes, 23 minutes, 33 minutes, 27 minutes, 32 minutes, 30 minutes, 28 minutes, etc. You have an average of 30 minutes and standard deviation of 5 minutes. So Gauss told that the population can be estimated from this sample by using Gaussian theorem. We call it as Gaussian theorem. So this is X bar, this is 30. 1 sigma, 2 sigma, 3 sigma, minus 1 times 2 sigma, minus 2 times sigma, and minus 3 times sigma. So this 30, one standard plus one standard deviation will be 35. This will be 40. This will be 45. This will be 25. This will be 20. This will be 15. Okay. We call this as lower control limit and upper control. Lower control limit and upper control limit. I hope you are with me. I hope it's not too technical. I hope I can go back to easier topics. See, today, many of you are getting introduced to CPHQ. So I could have kept it very simple also, but I checked with you. You are okay with the data analytics part. And this is all considered as to be very tough. We teach you much more than what is expected from you in the CPHQ, so that when you're facing the exam, it becomes so easy, very easy for you. So I hope you are with me. Yeah. I hope you are understanding or not getting confused. Yeah. So once again, I'm repeating. So how did I get my control limits? We got the control limits by collecting a small sample of 30 samples, let's say, and we obtained the standard deviation. And then we estimated what that 99% of the population, 99% of the population is lying between plus and minus 3 times the standard deviation. So these becomes our control limits. LCL and UCL. Lower control limit and upper control limit. I hope you are with me. See, 2-3 questions will always come from for control limit. One question may be histogram. We are learning all these things. Yeah. So they will not ask you to calculate standard deviation, by the way. So, but you should know that something like standard deviation exists. It can be easily obtained, but what are the applications? You should be knowing that. So here, you got the control limits, and these are the control limits. Means your average is 30 minutes traveling time. Upper control limit is 45 minutes. And lower control limit is 30 minutes. So we say that process is under control if it is within the control limits. LCL and UCL means if you are taking time between this is 15. Sorry for that. 15. So this is 15, right? 15 to 45 minutes. So we have 15 to 45, 30 minutes, 15 to 45 minutes. So if you take, let's see, one day you take 40 minutes, next day you take 35 minutes. It is expected behavior. It is normal behavior. It's natural behavior of your process, traveling process. Okay, so please remember this part, that a process is under control if you are behaving in a predictive way. I can predict your performance that you will take between 15 minutes to 45 minutes. This is, so we say you are under control. Your process is under control of traveling. But suppose one day you took 120 minutes. It's 2 hours almost. So I would say this is not typical of you. So we call this a special cause. Special cause means something special has happened. This 120 minutes is associated with some very special cause which doesn't occur every day. Yeah. So you can take an action, you can take a specific action on that cause immediately on the same day or within 2-3 days and try to manage it. This we call it a special cause. And the ones here within this variation is due to common cause variation. This variation is known as common cause variation. Okay, let me use the video to the reason I'm showing you the video, because what will happen, you can also watch those videos. This training also is recorded and is available, but you can also watch these videos in detail when you are you're searching for these videos in our channel. You can always the same thing, right?
To office every day, and I find that on an average I'm taking 30 minutes and standard deviation is 5 minutes, and we know how to calculate the standard deviation and how to calculate the average. Now if I plot the data on a histogram, then lower control limit would be -3 sigma limits, that will be 15 minutes, and upper control limit would be 45 minutes, that is plus 3 times the standard deviation. So lower control limit being 15 and upper control limit being 45, I can say that my travel time is going to vary between 15 to 45 minutes. So you can expect me to travel to my office every day between 15 to 45 minutes. If someone asks me why this variation between 15 to 45 minutes is there, I can tell him that it is due to common cause variation. What is common cause variation? I can say that the variation between 15 to 45 minutes is due to lots of factors. These factors can be the traffic on the road, the weather, the car I use, my mood, or it can also depend on at what time I start from my home. So a lot of factors, which we can call it as X factors, are affecting the travel time, which is the Y here. So I can make the statement that the variation between 15 minutes to 45 minutes is due to the common causes. Means all the causes are acting on my system and producing this variation. This is known as voice of process, as if my process is telling, my traveling process is telling that I will take between 15 minutes to 45 minutes. Now, if I take 60 minutes to travel to my office, then same question is asked to me, that why did I take 60 minutes? Then my answer won't be that all the causes are acting on my system and producing this variation of 60 minutes. I might be able to point out a cause. We call it a special cause. So I may say that I took 60 minutes because maybe today there was too much traffic on the road, or it can be any factor. So when I go out of control limits, I can specify a special cause, and we call this variation as a special cause variation. So we have two types of variation: common cause variation and special cause variation. Common cause variation is part of the process, part of the natural variation of the process, and special cause variation is assignable variation. I can assign a cause to that particular event. Now, what is the difference between common causes and special causes? For special causes, you need to take immediate action. Means you need to take a prompt action so that you are able to bring the process within control. But for common causes, you should not take any specific action. Usually, the common cause is within the control limits, and if you want to act upon the common causes, you might have to change the control limits, and changing the control limits takes effort. You may have to do a DMAC project. You may have to do a lean project. You may have to do a Six Sigma project. And that's what we are doing. That is why we say that lean and Six Sigma.
Here, any process improvement, means you want to change the control limits. Okay. You are changing the control limits. So if this is, let's say, waiting time of the patient, you are trying to reduce this waiting time, lower control limit and upper control. And by the way, these control charts are very easily made in Minitab or Excel sheet also. So we teach you how to do that in our class. So when you join our sessions, you'll be learning how to make control chart, how to, all these things, whatever I'm doing. Everything is very easy. They will not ask you to make control chart. They will not ask you, but they will ask you questions about control chart. So when you learn how to make them, then so easy for you. Okay, this is before and after. I just want to show you the before and after. See, one of the ways, to interpret before and after. Actually, I clicked. I made the graph which was supposed to be shown in the end. But so what is happening before you are operating somewhere here between some control limits, and afterwards you have changed the control limits. And how to change the control limits? Using root cause analysis. So what they did was they brainstormed on man, machine, material. This is known as 6M technique of generating the cause and effect diagram. So the cause and effect diagram, which you were seeing here while ago. Yeah. You can also generate keeping in mind the 6M, like man, machine, material, method, measurement, mother nature, so that you can generate more ideas. Okay. Yes, so here also you can get it if you have noted down your causes. If you've noted down your causes, you can ask Minitab to make the cause and effect diagram. So just few clicks, you get everything. Reasons for a delay. Now you brainstorm, you identify some 50, 60 delays which happened while discharging the patient. So I assign a reason for that. So first was due to discharge summary was delayed. I know another one, discharge summary was delayed, reporting was not accurate, attendant not available. So these are all examples. Some of the causes, they are appearing again and again, many times. Which cause is appearing more? So what you do, you make Pareto chart. You ask to make Pareto chart. Okay. It's telling you reporting not accurate, staff not available, and pharmacy delay and discharge summary delay. These are the 4 or 5 causes which are contributing to, like you can see here, 29% is the first one, 25% is the second one, 12% is the third one, and 8% is the fourth one. So in your exam, the chart will be given to you. You have to read it and you have to answer the questions related to the chart. So they will not ask you to make the chart, but you should be able to read the charts and answer questions from these charts. The control chart might be given to you, Pareto chart might be given to you, and you have to answer the questions. So here, as a project person, as a CPHQ professional, I will work on these root causes: reporting not accurate, staff not available, pharmacy delay. That is how we can proceed. And then you work on them, you get the solutions. And once you get the solutions, of course, you can. I think this was good enough for technical topic. Any other topic you want? Okay. FMEA, I think let us take FMEA. Okay, one of you have said FMEA. Let us do FMEA, failure modes and effects analysis. Now, FMEA link is given here. You can just watch that link whenever you are free. And let me show you what is FMEA.
imagining how each input will fail. Before we take an example on process FME, that is PFMEA at a high level, let us understand the various columns of failure modes and effects analysis template. FMEA has got a lot of columns. The first column is about process or the process step or the input. So you have to mention the process which you are trying to improve or the process step or the inputs. And the next column is about failure modes. Imagine how this process will fail, how the process step will fail, or how the inputs will fail. You have to write how it will fail. You don't have to write the causes, why it is failing. So one of the common mistakes is that people start writing the causes of the failures. You don't have to write the causes here. Causes will be written in the causes column later on. After that,
Sir, you're on mute.
Oh, sorry. See, I'll just show you an FME, very, very uh, brief FME. In the class, usually in the CPHQ sessions, we make the FME together along with the class. But obviously, we don't have so much of time here. So I will just show you. You want a day-to-day life example or you want a hospital example? When you're learning the tool, sometimes people prefer day-to-day life example, then we apply it to the hospital example. So what is your preference? Just give me one. Okay, so Amal is telling day to hospital, Anju is telling day to day. Okay, okay. I will show you first day to day, and then I will show you the hospital example. So this video actually contains the day to day life example. So the first is, let's say you want to improve your process of going to hospital. Sorry, every day you are going to hospital, you are going to office, right? So what happens here is you start with the identify the what are the things which can go wrong as you are traveling to hospital every day or any office.
And detection ratings. And finally, we identify the ways to reduce or eliminate risk associated with the high RPNs. To understand FMEA, let me take an example of a day-to-day process. For example, coming to office, this could be the process, and I will write that in the process column. So process is coming to office. What is the...
And I hope you are able to see what's written here. If not, you can expand the screen. And if you are on mobile also, you can do the same thing. Also, you can download our mobile application called Anexas. The link will be given to you. If you download, you will get all the access to this video in your mobile phone. Lot of tools and techniques videos are also given, and they're all part of your CPHQ syllabus and process improvement syllabus. You can always watch them in your spare time. This FMEA is also part of it. And by the way, this FMEA had garnered 2 million views on, if you, my team has already put the link. FMEA link, I think they have already put. Oh yeah. So let me show you, this FMEA.
Now, let me talk about a very powerful
it has
tool
got
called
2
failure
million
modes
views.
and effects analysis.
You can see that, right?
This tool,
2 million
FMEA,
views.
was first used by NASA
And
to send the people on the
every
moon.
day around
And
10,
they did not want to fail, and that is why they used an FMEA, failure modes and effects analysis. Typically,
yeah. Now coming back. Yeah. So first is process step, coming to office. Next is failure mode. What is the mode of failure? Means what will you treat it as a failure? Coming to office is a process. So our failure mode is late coming. What is the effect? Loss of productivity or salary deduction sometimes. How severe it is. So 1 to 10 scale, generally severity rating you have to provide from 1 to 10 scale. There are 3 ratings, in fact, you have to give. One is severity rating, one is occurrence rating. You can see severity rating in D column, occurrence rating and detection rating. In the severity rating, 10 means very severe, very bad for the customer. 1 means nothing happens. No one is even bothered about that issue. So that is severity. You have to give 100. So here we have given 8, means considering that you are a very important person and your absence really matters. So the severity is 8. Potential causes. What are the potential causes of your coming late? We have listed down here. Let's see.
Productivity, or sometimes it could be reduction in salary too. Assuming that I'm productive and assuming that the organization is really concerned about one of the cause could be habit. I'm just like that. Oh, so sorry to say. I'm productive. This failure mode. So what are the effects of coming late? It could be loss of productivity, or sometimes it could be reduction in salary too. Assuming that I'm productive and assuming that the organization is really concerned about my productivity, coming late is having some severe impact on the organization. So I would give a rating of 8. After that, I will move on to the causes. Here I will write down all the causes which are leading to my coming late. So these could be traffic, this could be accidents on the road, one of the cause could be habit. I'm just like that. Oh, so sorry to say that. I'm just like that. I'm habitual of coming late to office. And one more could be waking up late. For each of the causes, I will give occurrence rating, how often this cause occurs. So in the case of traffic, yeah, 50% of the time it is there. Traffic problems are there, so I would rate it as 5. Then accidents on the road, well, it rarely happens, so I'll give a rating of 2. Habit, yeah, habitually I'm coming late to office, so it often happens, so I'll give a rating of 8. And waking up late, oh, I wake up late every day, so I have given the rating here as 10. Next time. The next column is about current controls. Current controls means present controls. Right now, what are you doing to take care of these causes? So for traffic, I look at the GPS. For accidents on the road, I listen to the FM radio. So I get to know where is the traffic blockage and I can divert and take another route. The next cause was breakdown of the car, and what do I do for that? Presently, I have an yearly maintenance schedule of the car, and that's pretty well done. And that takes care of this particular cause. And habit, what do I do? Oh, well, today I don't have any control on that. Waking up late, what are the current controls? Well, I have an alarm clock. Now I am going to rate each of the current controls, and if the control is good, I will rate it as 1. If the control is bad, I will rate it as 10. So GPS. Well, GPS is, yeah, it is able to take care of this problem, and I'm going to give it a rating of 4. Then comes the accidents on the road, and FM radio is able to give me good information. So I gave it a rating of, say, 5 or 6. And to take care of the breakdown of the car, I had yearly maintenance schedule, and it's a really, really good control. So I'm going to give it a rating of 2. Habit, right now I don't have any control, so no control will always get a rating of 10. Waking up late, I had alarm, but it is of not much use. Alarm keeps ringing, I keep sleeping. That means it should be somewhere around 8. So I have given the ratings for detection. So I have now 3 ratings: severity, occurrence, and detection ratings. I am going to multiply these 3 ratings to get my risk priority number, RPN. So if we multiply these numbers, we are getting 160, 96, 32, 640 and 640. So obviously the maximum RPN we have is 640, 2 times. So we will work on them, and we will give some recommended actions. So here we have given a recommended action. To take care of the habit, I have got a recommendation that why don't I undergo soft skills trainings, motivational trainings, or why don't I think about my career or the salary. And For waking up late, I can have maybe 2 or 3 alarms, or maybe better still, I can sleep early and maybe I can tell my spouse to wake me up. Please note down that while we are making recommendations, we can recommend to reduce the detection rating. That means we can suggest a better control, or we can even suggest a method of reducing these causes, the occurrence of these causes. Naturally, better would be to reduce the occurrence of these causes. And if that is not possible, then at least we can reduce the detection rating, means we can put up a better control.
Sir, you're on mute.
Sorry. So here, if you look at, this is the process of pediatric patient handling, and we have done an FMU on patient fall. So the failure mode is here, patients fall down. Potential failure effects is injury. Then severity rating is 8. Potential cause. And if you have any questions, please ask, right? Please ask. If you have any questions, you can write in the chat box. So here we have listed down the potential causes of lack of awareness of family, lack of awareness of staff, wet floor, medication. Yeah. Services telling, is it compulsory to download the app? See, if it is, if you download, you will get access to those videos for lifetime. So otherwise, you can directly go to the YouTube or go to the link also. But at least subscribe. Just press the subscribe button. Then all the new tools which we update, you will get a notification and you can watch. In fact, see, even if you are not doing CPHQ examination or writing CPHQ examination, still these tools and techniques are very useful to you. So you can always use them to improve your processes and improve your career. Yeah. So I hope I have answered your question, Sarvat. So here, yeah, potential causes, these are listed. Now, how often it occurs in our setup? So the people who work in the process, they know it better. Then put the current controls. Current controls means what are the current controls today? What are you doing to prevent this? So we are educating the parents, but it's not a good control. So detection rating is very high. No, good control is, I hope you remember that. If you are able to control using this particular control, you are able to reduce the cause, etc. So it's a good control. Good control will always get a lower rating, and bad control gets a higher rating. Higher number is risk, more risk. And you have to then multiply. This RPN is nothing but multiplication of these 3 numbers: severity rating, occurrence rating, and detection rating. So by this time, I think you must have read this whole FMEA, how it is done. Any questions you have on this FMEA? Okay, great. So I think you have got a good idea, just let me know, did you get a good idea about the different aspects of data analysis, the tools, techniques? And I covered today, I covered the most difficult topics. They're the most difficult topics, and more and maximum numbers of questions that are coming from these topics. So this is something I hope not many people found it too difficult. It is very easy. Only thing is you have to learn, and we teach you. So if you are interested in our training program, please join. We have got, I think, my team. If you can put the dates of our next programs. And you can also watch my another recorded version of CPHQ training if you're interested. So there I have taken different topics. There I have spoken about different topics. So you can enroll for the CPHQ examination here. I think we are seeing some black box in front of, so we can unshare and share one more time.
Is it visible, sir?
Yeah, so these are the batches. We are starting November 29, December 6, 13, 20. These are the batch days, 4 days of training, or January 3, 10, 17, 24. So you can attend our training programs. All the video recordings are given to you. We have interactive sessions. We solve mock exams also. And we give you a lot of mock exams also. So go ahead and join us. Yes, these are the timings. And you can pass the CPHQ examination in first attempt conducted by NHQ. So our track record is very, very good. And you also get one certificate. So just by attending the training qualifies you for becoming CHQEs, Certified Healthcare Quality Expert. Yes, so this is the fees. If you are interested in joining us, this is the fees in dirhams, 1,500. And if you register today, you get at 1,200 Saudi Riyal or dirhams. And these are other upcoming free webinars. So I hope you got fair idea about what is there in CPHQ, and please do join in case you are interested. Please feel free to join other upcoming free webinars also. And I will be looking forward to see you in our CPHQ, in my CPHQ session starting from 29th November. If you attend one training, you can attend our other trainings any number of times. And plus, you can you can attend our CPHQ training any number of times, multiple times. So if you have any questions, I'll be happy to answer, and my team can play some video of CPHQ feedback, etc. Any questions? Yeah, please go ahead. You can play the video. We can't see the video here.
Hello friends, I'm Dr. Jyoti Bala and I have recently cleared my CPHQ examination with a wonderful score of 88%, and I'm really grateful to Mr. Amitabh Saxena and all his team. So Anexas has done a wonderful job training me for CPHQ exam. I could crack the exam pretty easily. The materials provided were very, very up to the mark, were very appropriate. I mean, I really had to work hard with them for a couple of months, but it wasn't that difficult as such. And I really wish all the candidates great luck, whoever are appearing for CPHQ examination, and I highly recommend Anexas training for the same. Thank you.
Yes. So right now I just met one person who has cleared the CPHQ examination, Dr. Shahnawaz. And
Yeah.
yes, doctor, you would like to say something about?
Yeah, I am Dr. Shahnawaz. I am a family medicine registrar currently working in Saudi Arabia. I got the training from Anexas from Bangalore, and I cleared my CPHQ exam 3 years back. It was so grateful for Anexas for training me.
Thanks a lot, doctor, and best wishes to you. He is in Riyadh right now, and we just met him in Riyadh. Thanks a lot. Thanks a lot. So we have many satisfied participants of our training programs, and we'll be happy to have you too. So thanks a lot. I think unless there are one or two questions I see. I am a recent MBBS medical graduate and was thinking to getting into healthcare management. Can you suggest a pathway? So Neeraj, I think you can quickly do any quality healthcare management is about a lot of emphasis is on that quality. You join our green belt and black belt training program. This will open up doors for you not only in healthcare management but any management, and especially if you're joining CPHQ training session, then that will also help you. So yes, after that your employability increases, and then obviously you can get a good job, and then your career would definitely skyrocket after that. And see, sometimes if you take a pathway of green belt, black belt, and master black belt also, then you can develop the skill to transform any hospital. You can solve any healthcare related problem. You can manage it. You can improve it. So that's the way. That's how I would answer your question. Thank you. Okay, and there are no other questions, it appears. Then I think we can. Okay, we can then wind up the session. Thank you. Thanks a lot. My team is there to answer your questions related to administration and also registration. So they'll be here for a while. And meanwhile, you can also watch some videos as you are here.
Completed 3 days training of the Hi, so I've just completed 3 days training of the CPHQ, which has been absolutely fantastic. Amitabh from Anexas has been phenomenal. The course materials have been fantastic. I think what I really enjoyed about this was that I could relate a lot of this methodology to healthcare, and a lot of the examples were things that I could contextualize it with healthcare. So I'm from here in Qatar at Sidra Medicine, and so again, thank you to Amitabh for this fantastic training.